I'm gonna, if you'll bear with me for the first 10 or 15 minutes, I'm gonna go through some science stuff, and I look at the diversity of the audience here, and I recognize that you're not all scientists, or you're experts in different fields, some of them not even science related, and I'll do my best just to sort of walk you through some of that. But without it, some of the things that follow won't make any sense. It'll almost seem like magic, and just trust me, there's stuff behind it. And I'd rather give you a little bit of background and then walk you through some of the studies that got us to the point where we're truly helping patients now. And this is, I'm glad I put this in, because after the last talk particularly, I think it's quality of life we're looking for, and not necessarily quantity. Now, with quality will come quantity, but not immortality. And so keep that in mind. And if we can take a message or a lesson from, oh, boy, you know what, this isn't going to work now because we had to switch this off. Doggone it. That's right, because I didn't move those onto the memory stick. But what you were going to see here was this wonderful little video of a newt or a salamander totally growing back his limb. It's actually the Howard Hughes Foundation did it. And how many of you have ever seen such a video? It's a time course thing. So these axolotls, it's the scientific name of these newts, that you can amputate lots of different body parts, and they totally grow them back, perfect replicate of what was there. And so they chop off the whole arm, and in about 8 weeks it grows back, and there's this time-lapse video, and then there's you could do the same thing with portions of the heart, even the central nervous system. It's just remarkable what these animals can do. And we can do that as early developing fetuses, but we lose that. That's the ideal outcome. If in regenerative medicine we could figure out how to return to the state where we could replace a missing or damaged part with the exact replicate, it'd be game, set, and match. We could all go home because all of our problems would be solved. And actually we're getting towards that. Understanding now, sequencing the human genome, understanding which genes get turned on when and lead to certain things. That's what we're looking for. However, following birth, we go through the following, and physicians and anybody in biology gets this. I'll go through it really quickly, but once we get injured in any way, or body parts start to wear out, typically it's injury, we get a little bleeding and the blood clots, and then a bunch of inflammatory cells come into the site. Some of the cells in the injured tissue, whatever it is, die, and others survive, and then another type of cell called a fibroblast come in, and all the dead tissue debris gets removed, and we end up depositing this connective tissue that forms a scar, and that's what we call tissue repair. That is the process of inflammation and repair that we all go through for injury in all of our body systems. There's a couple of body tissues that can truly regenerate. Could anybody name one or two? Liver's great. Liver's the most regenerative thing. Outer layers of our skin constantly regenerate, the lining of our intestine. But the rest of the tissues do this. And if you too severely damage even the regenerative tissues in us, well, they form a scar like this individual here. Now, regenerative medicine comes along and says, we've been working on some problems for a long time and really haven't made much in the way of progress. And things like stroke. We've done a great job now of teaching people how to deal with their deficits, but we haven't solved that problem at all. We haven't even solved diabetes. Yeah, we can treat diabetes, but we haven't solved it. You get a spinal cord injury, and we don't know how to regenerate that. You have esophageal cancer, we don't know how to fix that. We take your esophagus out. So we've been using traditional methods of medical research for a long time, and not making much progress. So regenerative medicine comes along and say, let's see if we can think about it from a whole different perspective and make some progress. And to go through this whole system, what you probably can't do is go through everything, get down to the end, magically do something and get a different outcome. You probably have to intervene early. So I was thinking about the things that progress what have been the major advances in medicine for the past 150, 200 years? And one is hemostasis. We don't bleed to death very much anymore unless you rupture your aorta, you're not in an ER. We can control inflammation through a lot of different medications and physical means, and our biggest advances have been in surgery. I mean, I don't know, how many of you have ever been in a surgical suite other than a patient? I mean, as it's watching, yeah, I mean, it's remarkable. Surgeons are incredible technicians. These guys are so well trained. They make the most sophisticated things look routine. They've got your heart in their hands on a daily basis, so in tiny arteries, you know, they're in your brain doing things. And we get upset when it doesn't go right. It's remarkable to me that it does go right as much as it does, and our instrumentation's terrific. Now everything's microscopic, laparoscopic, endoscopic, arthroscopic, everything minimal. But fundamentally we haven't changed this process. We just have smaller scars. We don't hurt as much anymore. We're out of the hospital quicker. But we haven't fundamentally changed this process of inflammation and healing. So if we're going to change, we have to get up there early, and this is where regenerative medicine people come in. They get up there and they throw in stem cells or some other intervention and change that initial response from the inflammatory cells to, we'll call them constructive cells, because you can upset some people if you call them certain things, which means everything downstream changes. So if we're successful upstream, we can totally go on a different path and try to repair tissues. That's really what it's about. And so people in this field called regenerative medicine start with either cells or some type of a scaffold or some molecule, a drug of some type that makes the cells do certain things. And then, of course, at the end of the day, they all have to come together and form a tissue. So clearly we need the cells. The question is whether we put them in there, like we're likely to hear from Professor Snyder later, or we somehow manipulate them. And cells represent the huge, it's the 800-pound gorilla in the room of the people working in this field trying to do that. Now that being said, most people think of tissue engineering and regenerative medicine because of that human ear growing on the back of the mouse about 20 years ago. And that is where this ear was grown the template was made outside the body, put in a bioreactor and put in the mouse. The idea was if we could grow this ear, take it to a patient, and we'd be able to grow body parts. We're 20 years down the road. That doesn't work. And what's the reason? Why doesn't that work? Because we can grow a lot of things. You see a lot of this now in bioprinting too. You know, we get these fancy, great videos of organs being bioprinted. And the reason is because how do you hook it up? How do you hook the plumbing up? How do you hook the nerves up? How do you and all of the other things it's impossible. And to bioprint something, you need to know exactly what you want to print. And if you don't have that template, you make little mistakes along the way. So that paradigm, in my opinion, is going to have very limited success. There's a couple of products on the market now where it's basically skin in a bottle. They're called Dermagraft and Apligraft that are reasonably successful. The better paradigm, in my opinion, is skip the bioreactor part, let the body be the bioreactor. Because Mother Nature really knows how to do some things that we just have not figured out. And we can spend a lot of time trying to figure it out, or we can use what's already there, which is the body. So a lot of that's working. So I went on to clinicaltrials.gov the other day, and there were over 5,000 registered stem cell trials going on. 5,000. Now, that doesn't mean they're all active at the present time. Some are not and some are, but that's a lot of resources, a lot of money, a lot of time, people's time, a lot of patients and such. So then I asked the question, I'm a physician, and what condition comes in the door now where we routinely treat it with stem cell therapy because it's better than the practice of medicine? Anybody? I can't think of one. It's used a little bit in plastic and reconstructive surgery. Fat stem cells are used to augment certain tissues and provide a cushion. But we haven't changed the practice of medicine with all of the resources. Now, that doesn't mean it's not going to work. In fact, I'm a firm believer in that whole approach. It will work. We will figure it out. But I think the reason that it doesn't work is because most cells that we put in there don't survive, which is unlike with the original intent. Now we recognize that they have effects, that they can affect other cells around them, but we also put them into abnormal environments. We take these stem cells out of the body, we try to expand them in culture, make more of them, and then we manipulate them some more, and then we take them back and put them into an area where we want them to do something good, a scar of a patient who had a heart attack or spinal cord, into abnormal places for them, and expect them to turn into normal cells that are going to do normal things. And that just isn't the way it works. So the environment into which we put them, in my opinion, is largely one of the culprits, one of the bigger culprits in us not working. So why don't they survive? It's because of this manipulation outside and this abnormal environment that we're putting them in my opinion. I'm very anxious to hear what Dr. Snyder has to say about this as well later. So stem cell approaches, which is what most people think of with regenerative medicine, have got some big challenges ahead of them. But we're learning so much every day, every month, every year, that we will eventually figure some of that out. Here's an alternative approach, though. Instead of manipulating stem cells that we harvest from your umbilical cord or your blood or your fat cells or wherever, or your bone marrow, why don't we take a note from Mother Nature and figure out what it is that normally attracts stem cells to sites of injury? That's why they're there. They're a reserve cell population for us to replace tissues. Now, eventually, as we all know, and what the topic of this day is, that eventually doesn't work anymore, right? And we die from something. But if we can attract them to if we can put a homing device at a site of interest, get them to the site, and then treat them nicely, we may end up with some better results. So this is what most of my efforts have been associated with over the past 20 plus years. It's what's another part of the native body, what's called the extracellular matrix, and what it basically represents is the environment in which every cell in our body, in every tissue, your brain, your fingertip, your muscles live. Every cell secretes things outside. If you think of this, think of a single cell organism, an amoeba, it does the same thing. It secretes things. It's just that in a multicellular organism like a person, it serves as the interface with adjacent cells in many cases, and it's the structural and functional support between cells. It basically is the microenvironment in which every cell lives and survives, and so we can instead of just being a physical structural support. In the past 20, 30 years, what we've really come to figure out is that that's probably it's an important function, but maybe secondary to the information highway that it represents between cells. It's basically, it tells the next cell, you should move, you should divide, you should differentiate, you should do these things. So it's loaded with this type of very useful information, and we can harvest it by taking a tissue and getting rid of the cells. We call it decellularization. And so this is two different forms of extracellular matrix. Up at the top, that's the extracellular matrix from a urinary bladder of a pig. And this is the liver of in this case it was a rat that's been totally decellularized. No cells in those, just the matrix, just this information package that's there. And you can take any tissue and do it. And the molecules that form the extracellular matrix turns out are so important that through evolution they've been highly conserved between species. So everybody knows you can't take a pig kidney, put it into a person because it'll get rejected. You can't take pig cells, horse cells, any cells. You can't take a human cell from one of you and put it in another without there being rejection problems. But you can take matrix from even different species, put them into a separate species, and not only do you not get a bad reaction, you actually get good things happening because of the information that's there. Well, that was pretty key. That was important. And it's got all these different types of molecules in there that people spend their life studying. I'm going to give you 3 examples of studies that we've done over the past 20 years or so that got us thinking along a certain way. And that is, had a graduate student about 15 years ago, and the Achilles tendon is at the back of your heel. It connects the muscles in the back of your leg to your heel. And we took out about half of it and replaced it with a little piece of this pig extracellular matrix. And on the left, what you see is the response after 2 weeks. And all of these cells in here, these dark spots, they're all new because there was no cells in what we put in. So the body responded, and if you send that to a pathology lab, one of the things I trained in is pathology, I guarantee you that comes back as inflammation. The body's responding, there's inflammation, and we all agreed earlier that the inflammation ends up in scar tissue, but if you wait a couple of more weeks, what you end up with is that blue structure that is essentially an absolutely normal tendon. And you can isolate those cells, they've got the same gene expression patterns as tendons and so forth. So why didn't it turn into a scar? Okay, maybe it was a coincidence. So did the same thing, took the same different type of extracellular matrix from a pig, put it into a dog, where we took out the disc, the little cartilage that sits in your temporomandibular joint. This is a big problem, mostly for women. They get a TMJ problem, and the disc degenerates. Well, after a couple of weeks, same thing. Loads of cells, looks like inflammation, but it turns into a structure that's straight fibrocartilage and is indistinguishable from a normal disc. Well, why didn't it just turn into a scar? We went through this process of inflammation, but it ended up with something that was much functional and constructive. If you do the same thing and you take out a couple of layers of the muscle in the body wall, a couple of weeks later you get inflammation, quote inflammation, but a couple of weeks beyond that you start to get islands of new muscle forming instead of scar. Now it's not normal tissue, but it's certainly not scar. So we thought something weird's going on, you know, and I could show you 15, 20 other examples of the same type of thing that was happening. So the message was, these matrix scaffolds can change our default mechanism for responding to injury. Now recall, I said one of the biggest problems is the scar tissue we form. We don't reform injured tissue, and eventually these things add up over time. Well, okay, so something in there is that. So what is it in the matrix that does that? Now I can list 4 things here that we couldn't list even 12 years ago. First is whatever we put at the site of injury, whatever your injury is, and one of the nice things about talking to an audience at this age is we've got lots of problems. I mean, I'm in this group, trust me. I mean, you know, I'm going to give you 3 examples of human conditions at the end, and I will bet that there's multiple examples. Either know somebody or you've got these problems. It's got to go away. Whatever we put there needs to go away, because the body responds to anything we leave there by saying, you know, you don't belong here, so I'm going to either wall you off or I'm going to get rid of you in one way or another, destroy you. So it's got to be a temporary support. And one of the most interesting things, and this is Mother Nature's done this, this is where evolution really, I mean, you can't deny the advances that have occurred, that biology, our present-day biology knows that are the product of evolution. All of these molecules that form the extracellular matrix, at least a lot of them, when there's damage and injury and the body comes and responds to the injured site and starts to break things down to lay that scar tissue down, it breaks up these parent molecules and creates what are called cryptic peptides. They're sequences of the amino acids and proteins and such of the parent molecule that now are new molecules that are active in their own right. And they've got really interesting properties. Some of them are antimicrobial that get released at a time of injury. Many of them recruit stem cells. Many of them cause new blood vessels to come in. Some of them actually inhibit blood vessels. Others moderate our inflammatory response. So this is really beautiful because Mother Nature's figured out, okay, you don't need these things going on when we're normal and healthy very much, but at times of injury we do. So these cryptic peptides that get created only get created from the matrix molecules. And if it's injured tissue where you've got cells that get damaged, now you've got this mixture between inflammation and these good things trying to happen, and you end up with scar tissue in us. By taking the cells out so that you don't have the cell products promoting that inflammatory response, you end up with only these constructive molecules there. It's a simplistic way to think about it, but has a lot of merit. We know that we change our immune response. Now, a lot of times you think that's bad. We need our immune response, and we do. But there's a good side to the immune response and the inflammatory side of the immune response. And the other thing that happens is we recruit stem cells to the site. Now, all of these things happen as a result of these matrix molecules. And so this is getting to the end of the science part of this. So are you with me so far? Do you understand what I'm saying, how these things work? Let me give you a couple of examples. So I had another graduate student who would, this is the equivalent of in the middle of your middle finger, amputating it. It will never regenerate. And this is what happens in these mice every day. Within 14 days, they do this every time. They just, here's the cut end of the bone up here. This is scar tissue, and this is the overlying skin. Happens every time. I mean, it's like clockwork. If you take the extracellular matrix from a pig and you treat that site, it looks like this after 14 days. Loads of these, quote, inflammatory cells, like I showed you before. And it's certainly not healing quote, healing normally. So what Vineet did was said, what are these cells? So he micro-dissected these cells out, and he put them in a culture tube, and they separated all the cells from each other, and he put them in culture, and they started to grow. Now, if they're simply inflammatory cells, like macrophages and neutrophils and these different types of inflammatory cells, they shouldn't proliferate. Those are supposed to be terminally differentiated cells. But these things started to grow. And then they grew more, and he would take them, and he took these cells, and now he put them into media that people who do work in various, basically in stem cell biology laboratories, and he put some of them in a media that promotes stem cells to form nerves. And they start to send out these long dendritic processes, and they stain positive for things like beta-3 tubulin and other markers that are positive for neural stem cells. Well, that's pretty interesting. So you take the same cells, instead of putting them in that media, put them in a media that forms fat tissue, and they stain positive, and they turn into fat cells. And he could do this for muscle, cartilage, bone. He could do it for all these different tissues. So think about this. This is the distal tip of a mouse's digit being treated with a pig's extracellular matrix, forming cells that can turn into all three germ layers even. These multi-potential stem. Now, isn't that what we're trying to do with stem cell therapy? Get these types of cells at points of interest so they can turn into the right things. Now, in the Newton salamander, they know how, they're pre-programmed, they do that by themselves. They don't do that here by themselves. They may need a little bit more help, but at least we've got them there. So we definitely have changed that response to injury. And if you do what's called flow cytometry on them, you can get markers on them. And some of these markers, like CD146, NANOG, SOX2, these are pretty primitive markers for stem cells. These guys are way upstream. And then, interestingly, two of the other ones, 11B and this, are also markers of macrophages. And this is really one of the more interesting science things, because these macrophages, these inflammatory cells, aren't supposed to co-express stem cell markers and vice versa. So what is it? A stem cell that's expressing macrophage markers, or vice versa, or something in between? So about 15% of these cells do that. And we need to figure that out. But the message is something in our extracellular matrix can change the default response to injury, recruit stem cells to the site of interest. And so Vineet took this further, started to fractionate it, and put what's called, did this little thing, it's called a Boyden chamber or transwell, where you can put pieces or these fractions of the matrix on one side and put cells on the other. And the cells we decided to use are a very ubiquitous stem cell called a perivascular stem cell. Something else Mother Nature did. And one of the things you'll find me continually going back to, that if we really want to make progress, I think, in regenerative medicine to form normal tissues and get to the whole longevity thing, we really need to work with Mother Nature rather than try to fool her and trick her into doing something that she doesn't want to do. Because remember that old commercial, don't mess with Mother Nature. I think that's very true. These perivascular cells sit around small blood vessels, and blood vessels go to almost every tissue in our body, and they normally sit there and don't do anything. And I'm not going to go through the details of this, but the bottom line was that there's no doubt about it, what's called chemotactic. There's a homing device property of these extracellular matrix molecules for all sorts of different stem cells. Makes perfect sense. This is what she's put in as her mechanism to say, okay, now's the time we need you guys, when the matrix get injured and breaks down and so forth, because we need to mobilize you, get you over here, because we need some help getting things done. So we can definitely get these things there. One last little lesson in science, and that has to do with our understanding of inflammation. Every time you hear the word inflammation, most people have sort of a negative thought process. It's going to hurt, it's part of a response to injury, and if it goes on for too long, it's not good, and so forth. And the bottom line of this particular slide, which I would explain in more detail to people who worked in this field, is that the cells, the M0 cells, these macrophages, which is one type of inflammatory cell, can do everything we always predicted they would do. This is what we always thought they would do. But about 20 years ago, the people who work in cancer said, there's loads of these cells around all these tumors, and the tumors are growing. What's going on? What they found out is they look identical, but they do an entirely different group of activities. They secrete different cytokines and chemokines and all of this, but they look identical. So they've always been there. We just never figured it out. Well, what's their normal role? And the thing is, these guys over here, called M2, are really important in development, in shutting down the pro-inflammatory response and making good things happen. But they look identical. So maybe a lot of those cells that we were looking at earlier and saying inflammation were this type. And so we did a study, and I'm going to go through these so we can get to the fun part of this, where we took some biomaterials and put them into the body wall of a rat, where we look at how the body responds to them. And we took this is just normal body wall that was taken out and put back, and that's what's called an autograft. I mean, theoretically, it should be very friendly. This is one of these pig extracellular matrix that's been chemically cross-linked so that it's strong, but it doesn't break down. And on the top is the normal extracellular matrix. And you can see over here we get three totally different outcomes. And so what another student of mine, Jolene Valentine, did was basically show that in the good outcomes, we get all those cells ended up being M2, or a huge majority of them. In the typical response, they were all the pro-inflammatory markers. And we went on then to say, this is pretty interesting. This is less than 10 years ago that we did this. And we went on and we showed that the same thing happened regardless of the number and type of biomaterials that we evaluated. So this whole pro-inflammatory, anti-inflammatory macrophage story is becoming very interesting, and these cells, as it turned out, talk a lot with stem cells about what they do. So we went further, and we took, without explaining a lot of these markers to you, what I want to show you is that SIS is matrix from the small intestine. UBM is matrix from the pig's urinary bladder. Muscle is obviously from muscle. Brain, spinal cord, esophagus, no matter what tissue we isolated the matrix from and exposed naive macrophages to it, they always went to the constructive M2 type of a phenotype. So what Mother Nature, again, has built in to all of our matrices, and that of a pig and a horse and a rat and dinosaurs probably, is this ability to basically promote these constructive, that she wants to try to help us heal these tissues back. But we've adapted into these protective scar tissue forming things as a survival mode, and that's why we are what we are. So can we shift that balance a little bit so that we only get the constructive signals and minimize the scar forming signals? So another student of mine, and in the interest of us trying to keep us on time, I'm going to again go through quickly with this. There's a problem called volumetric muscle loss, and this relates to one of the clinical things I'm going to tell you. And that's when muscle can regenerate a little bit. But if you injure too much muscle, it's called volumetric muscle loss. The muscle can't recover, and you end up forming a big scar, and it's not very functional. So Brian Sakari and a couple of other people in my laboratory developed this mouse model where we could take out 70% of the muscle and was essentially your quadriceps, and then insert these little pieces of extracellular matrix. And then what we did was look at them, and over on the left-hand column, the top row, what you see is what happens normally. You end up with nothing filling that defect and a little scar tissue forming near the surface. If you take this matrix material, put it there, you get this accumulation of these now becoming familiar looking cells. And then if you look at the types of macrophages that are there, in the normal response, the red dots that you probably can't see above the dotted line, which is the injury site, are all the pro-inflammatory type of macrophages that are there. But if you put the matrix there, you get the same looking cells, but they're all the M2 phenotype. A clear demonstration that what we learned on the benchtop now also happens in a mammalian system of the same problem. And we also get mobilization of these perivascular stem cells that reside around these blood vessels. They're at 7 days, we see these blood vessels with these stem cells around them. And by 14 days, though, now these cells are moving away from these blood vessels out into the extracellular matrix, which is good. We want that to happen. And eventually they form these green staining cells, which are normal muscle cells. That normally doesn't happen. So The message of all of that stuff was we can change the default response to injury, which is what we want to do. That's that original thing. How can we make advances over what we've been doing in the last 150 years? So this is how do we translate this to people? So the Defense Department funded us to basically see if we could take things like this muscle story and translate it to people like the soldiers that are coming back from Afghanistan and Iraq, victims of roadside bombs, and civilian population that have these horrific muscle type injuries. And so this is the clinical translation part of it. So we've just completed doing 13 patients. And they ranged in age from 18 to 70, 7 different anatomic sites. They had injuries up in their upper limbs and in their lower limbs and all over the body. And as you can imagine, no two injuries are alike. Everybody's got different amounts of muscle loss, different muscles that are affected, and lots of different causes of injury, skiing accidents, roadside bombs, wakeboarding, motor vehicle, you name it, that we got them. On the average, there were 55 months between their initial injury and when they entered our study. And this was important because we wanted patients that had been treated by the standard of care and basically didn't get better, couldn't get better. They had an average of 10 previous surgeries, everything trying to take down scar tissue, move muscle things. Nothing worked in these patients. They were ready to give up. Most of these patients were really, truly accepting of an amputation. And the bottom line, we did that because if we did something early and they got better, the criticism would be, well, how do you know they wouldn't have gotten better anyway? So we need to start this way. Doesn't mean that we shouldn't be doing it early, but that's how we needed to start. And the average amount of muscle that these patients had lost was 66%. So 2/3 of a muscle group. Just imagine losing that much muscle in your upper arm or your leg. I mean, you obviously would have terrific problems. And these patients were patients that couldn't get out of a chair without help. They couldn't walk up or down steps. They couldn't reach down and pick up their kids. They couldn't get out of a car. They couldn't do things that we take for granted just sitting here. And so they were pretty desperate. We used 3 different types of extracellular matrix. The other thing we did in this study is we brought them in and said, okay, we recognize your problem, we've identified it, you're a potential candidate for this study, but in order for us to bring you in and try this procedure, we're going to put you into extensive physical therapy. So we had a group of very talented physical therapists say, okay, I see what your problem is, and here's the exact type of therapies that you need to do to get better. Because now they'd all been through physical therapy but hadn't gotten better, but we wanted to give them the best of care, and we would put them in that therapy program for anywhere from 4 to 16 weeks, however long it took to get them to a point where they no longer could get any better. And all of them did improve, showing that you could get better than what they had been. But then they plateaued and couldn't get any better. Then we did surgery and took this matrix-based approach. Why'd we do that? Because we didn't want someone to come along later and say, well, the only way they got better because you finally focused on the right type of physical therapy. So that they've failed everything in terms of our medical surgical treatments, and they've maxed out in what they can do. And our criteria for them saying it was successful is that they had to get 25% better in daily functions than they were in the preoperative max where they plateaued out. So we were very conservative in this study. And then we would do surgery, and there's a couple of pictures in here that might, I hope I don't offend anybody, but you've got to take a look at the degree of injury. So this is a Marine from Afghanistan who had a roadside bomb. He'd been 4.5 years out, and we took out all the scar tissue. This is the entire length of his quadriceps. Placed one of these matrix scaffolds in there in the appropriate way, began him on physical therapy, and this was one of the key things, immediately. Now, with that degree of surgery, if you were a group of surgeons, I would ask you, how long would it be before you'd begin aggressive physical therapy? And the answer uniformly is 6 to 8 weeks. Let him get over the surgery, and we'll work on rebuilding. Now, the reason I went through some of that science was because if this works, one of the ways it does it is by recruiting your stem cells to the site of injury. those stem cells get there, then they say, okay, what do you want me to do? Now, if you don't have that muscle group doing what it's supposed to do, the stem cell, I guess you don't need it, maybe it becomes a muscle cell. I'll just become a connective tissue cell, or a fat cell, or something that's not. So we start them into physical therapy within the maximum, longest we ever waited was 48 hours, most of them 24. That's so far against the practice of medicine right now that it's not even funny. And this is going to be one of the biggest things in clinical translation, getting this point across. And we took images of them. And so this is what this matrix material looks like right after surgery. This is about a month. And if you look at it 7 months later, you can see it's turning into some other type of tissue that looks like the surrounding tissue. So we can look at it non-invasively. And if you look at this piece of tissue here, this here is fluid, but here is the extracellular matrix. And here you can see it's starting to change and look like the tissue around it. So we can't tell exactly what type of tissue that is, but there is a way that we followed these guys. And then in some it's very clear. Here was the deficit in this particular patient, and now we've got something that really looks like adjacent muscle quite a bit. So some are better than others. So okay, that's fine. We've got pictures that look like muscle, but how's the patient doing? So, right, and that's the bottom line. Our primary criteria was function. So how strong could they get? So remember that pre-op max? So by 6 to 8 weeks, the average improvement was 15%, 21, it just kept getting better. All right, that's strength. It still doesn't mean necessarily you can get out of a chair. So you can take range of motion, because that's one of the biggest problems. All the scar tissue keeps people from being able to bend their legs or their knees or their arms enough, and they can't function daily. That got markedly better as well. And this is an example of the type of graphs we made for each patient, but each one's like this. So you can take this guy over here. So this guy lost a lot in his what's called anterior tibial compartment, which is below the knee. So he had a single leg stance test, eyes open, eyes closed. How far could you reach forward? Because you need that muscle to keep you from falling over. Backward reach, how far can you jump? So they had all of these things that are very important just to do everything, and we monitored them. And you can see that in most of this, for this guy, most of them all were on the upward swing. They all got better, and some of them markedly better, 100%. Sometimes we'd come into where one function didn't get better, but others did. And so we did this for every patient, and I just showed you this as an example. And so the average improvement, and this won't follow either because I didn't copy these over on the video, but basically what it shows is this is one of the patients who had lost all of the muscle in here, and he was supposed to try to then raise his butt off the ground, and he gets about 5 of them done, struggling, grunting, and it's really painful for him. And then by 6 months, he's doing these things like a Marine, and doing them up and down. So clearly, it's just a dramatic example of the type of functional improvement that you can get. I'm gonna try it. I don't think it's gonna. Oh, I am gonna get a little bit. As you can see him, look at his face. He's really struggling. He's compensating by doing other things as well, and I won't bore you with any more of that. But here's what he was looking like, the 6 months later. He could go. He went on, and clearly. So we did this for every patient. We took biopsies of them, and you can see that the pink stuff is new muscle tissue. This is within 2 months. This is within 3 months. This is within 6 months. So we're getting more and more muscle tissue. So I'm going through this because this doesn't happen. I mean, we've been trying for decades, hundreds of years, to get this sort of new muscle tissue to form. And it just doesn't work. And so this is basically taken those principles I was showing you earlier as an example of the type of problem where now we can make a significant, this isn't regeneration, because we don't have normal muscle at the end of the day. But we can form new functional tissue to take people from a very compromised quality of life to a better quality of life. All right, and I won't bore you with this, but the same thing happens with the stem cells and such, and we can also show that they have normal electrical activity. Basically, they're innervated. How many in here have gastric reflux? Yeah, I do too. That's about right. It's about 10 to 20% of patients, people have got gastric reflux, and about 10% of those advance to cancer of the esophagus. It's the most rapidly increasing type of cancer, not only in the United States, but in the world. You can see the incidence of colon polyps is about 0.58% per year. The condition called Barrett's esophagus, which is shown up there, is about the same. Barrett's esophagus is the advanced product of continuous reflux in the lower esophagus. Basically, gastric juice gets pushed up into your esophagus. We call it heartburn. And the esophagus starts to say, hey, if you're going to treat me like a stomach, I'm going to start to look like a stomach. So the cells start to change, and then they eventually become cancerous. Polyps, we do a colonoscopy, we take out the polyp because we know it has a high chance of becoming cancer. So why don't we do that up here? Because if we manipulate the esophagus to get rid of this tissue, the response is scar tissue. And we end up with a stricture, and we can't swallow. So the treatment's worse than the disease. So what do we do for these? This is another one of these things that we haven't made very good progress on. And so we wait, we watch, we put you on things like proton pump inhibitors like Prilosec and other things, and we end up then, if you go to turn to cancer, we take your esophagus out, and they drag your stomach up through your chest, hook it up to what's left of your throat. 50% problem rate, complication rate. And that's our standard of care. That's the gold standard. Come on now, we've got to be able to do better than that. But that is the gold standard right now. So if these principles of can we reconstruct tissues, minimize the scar tissue work, we said we did about 10 years worth of preclinical work saying, gosh, this looks like it's really working in the esophagus. So that's the stricture that tends to form, and this esophagectomy is horrific with all of the problems. This is an actual human patient having his esophagus removed, and they tubularize your stomach, and like I said, pull it up through your chest and hook it to what's left of your esophagus in the throat. It's pretty gruesome. So I'm working with a surgeon named Blair Jobe, and let me stop that for a second so I can describe what we do. Remember, if you take out the lining of the esophagus, you end up with a scar. So we can put the patient under anesthesia. We go in with an endoscope down the esophagus, and we take a scalpel and we cut all the way around the junction between the esophagus and the stomach, through that mucosa down to the muscle layer, but not including it. And then we come upstream to however far the lesion is, and we do the same thing. And then we tunnel down at 2, 6, and 10 o'clock, and we infuse some saline and other stuff, and we basically try to lift off this diseased mucosa. Then we go in and down at the stomach end, grab onto it, and what you're seeing here is the second patient that we did, where we pick it out and we pull it back out through. It's kind of like taking your sock off inside out. So what you're seeing is his entire lining of his esophagus being denuded from the muscular layer of the esophagus. And this is pretty dramatic. Yes, 5 minutes. Yeah, we're just about done. And this will form a scar every single time. Guarantee it. And so what happens? Let me see if I can go to the next. So this is what's taken out, and now you've got something to give the pathologist. He can tell you how bad the disease is. We take a piece of this pig extracellular matrix, wrap it, put it into a tube, put it over a balloon, run it down the esophagus, blow up the balloon, and wallpaper the inside of the esophagus. And we take one of these stents and hold it there for a couple of days so it can integrate in and we don't end up swallowing what we just put in there. And this is what it looks like over time. Now, here's the denuded esophagus. Here's the stent holding the matrix in place. That's what it looks like after we take the stent out. We've disrupted that surface. And now, progressively, we've done 11 patients now. All of them are at least 4 years out. Total replacement of the diseased esophagus, and all of them had cancer. This wasn't just inflammation. All of these patients had cancer, and they were non-operative for other reasons, cardiovascular disease, age, whatever it was. And this is the normal mucosa that was replaced when we biopsied it after surgery. The most traumatic thing, though, so these patients not only were given a death sentence because they went home and were told, look, we can't even do an esophageectomy on you, get your affairs in order. This is Dr. Jobe with the patient number 2, Mike Wright. He's from Ohio, great guy. Now he's about 80 pounds heavier now. We're getting on him about that, but because he's eating well. But this is the day after surgery. Day after. Now, normally in the esophagectomy patients, they're in the hospital 13 days, huge bills, 50% complication rate. And he's eating a normal diet absolutely immediately. So this is something where we can make a dramatic difference. I'm going to spend 2 minutes giving you what I think is the future of regenerative medicine. This is whole organ. And this is going to happen. And the only thing keeping this from happening right now is funding. Because this is not, there's no big discoveries that are needed to be made. It's simply a matter of doing some engineering. And so let me tell you about liver disease. It's 90% of patients waiting for most organs die on the waiting list because the donor organ shortage. Liver's no different. So the idea of whole organs is to take a donor organ like a pig's liver, and then you decellularize it. So you'll end up with nothing but the matrix. Then you take the patient's stem cells, the patient's own cells, and differentiate them and to put them on this matrix and encourage them to differentiate into liver cells. Then you might put it in a bioreactor to let them get a head start and then implant it, or you can just go directly. Now you've got a customized new liver for you, or a heart, or a lung, or a kidney, or a pancreas. And there's people working on all of these organs around the world. There's only about 20 groups total working on it because not many places have the resources to attack it from all the different angles. But now, what else do you have? You have not only you don't have to worry about a donor, somebody dying to get you a liver, but you don't need immunosuppressive therapy either because they're your own cells. Now this is really getting to a point where, because most of us are going to die from a major organ failure unless there's we have an accident of some type. Now we're starting to replace organs, right? So how far can we go, with this sort of a process? So just to show you what these decellularized things look like, they're pretty impressive looking. They're like ghosts of the original organ, but they've got no cells in them. And then we can seed them in different ways. So here's just to show you that this probably won't work either. No, because the videos didn't come over with it. Basically, what it shows is we inject a dye and it goes in and it maintains, because the vasculature and everything's maintained. Well, so we don't destroy it. And then we can introduce cells that turn into endothelial cells and reline the blood vessels that are there. And then we can add the liver cells that are there. And this approach is inevitable. If somebody dropped $5 million on us right now, I can almost guarantee you that we would do that within 24 months. The problem is nobody in our community gets that type of funding to do that. So it's probably going to take 10 years rather than 2 years. And just imagine the healthcare dollars that would get saved, by the patients that would benefit right away. Anyway, so this stuff's going to happen. And remember, it's quality, not quantity of life that we want, in my opinion. Thank you very much.
Thank you very much. It's fascinating, just fascinating work. And we have time for a few questions, and then we'll have a 10-minute coffee break.
I think I missed the part of where does the ECM come into this regeneration that you just showed in
the whole organ stuff?
Yeah.
That's when you decellularize an organ, take out all the cells. That's all that's left is the extracellular matrix. It's the three-dimensional extracellular matrix. That's right. We've decellularized the organ, so we've got the same goodies in the matrix. Yeah. So it's very. Actually, that's easier than a lot of other things that we're trying to do. Yes, sir.
When you talked about the muscular regeneration, you were always talking about traumatic injury. Does the same apply for degeneration of muscles through aging or other causes?
It works to some extent through aging, what's called sarcopenia, but it won't work for things like Duchenne's muscular dystrophy because that's a genetic defect. And all we're stimulating is more cells that have the same defect to come back. So we can't solve that problem unless we do some genetic manipulation of the cells that would be put back.
How about nerve damage?
And the thing I had to rush through on the muscle is that the fundamental difference of letting the body be the bioreactor and reform the tissue is that it starts to remember, okay, when I form tissue, I need blood vessels, and nerves come with blood vessels, and there has to be lymphatics and other things in there. So they grow in with the tissue, and that's definitely happens in all those patients. That was some of the electrodiagnostic testing that we were done. The traditional approach, saying we're trying to engineer the nerves, engineer the blood vessels, put them all separately, then try to me, that's just never going to work.
Okay, this is personal. That was my question. I've had 3 Achilles surgeries, and now I've got some kind of nerve damage. Would you take me right now? Would you take me with you?
Yeah.
Would you do a study on me? Because I have this nerve damage. I
Out in
can't.
the parking lot here, yeah,
I'm not joking.
I
I'm
know you're
serious.
not. I know, because I know how frustrating that is. If your nerve is functional upstream, so that because there has to be some place that the innervation comes from that's in a surrounding healthy tissue, which I'm sure you have. The answer is yes.
You will take me. I'll call you
We're
later.
willing to-
Give me your card.
We're willing to evaluate you. Yeah, absolutely. You'd be a candidate for that. That's a continuation of that study, because it's a musculotendinous tissue study.
Is there a shelf life to the ECM material? Can you store
That's
it for
the beauty.
years?
Yeah, that's the beauty of that. It's years. We have never gotten. I've had ECM on our shelf for 5 years. Used it. You can't tell the difference from the freshly isolated, because you can store it in a dehydrated state. You can sterilize it. You can do all these other things. Yeah. No, obviously the cells got a little bit more of a problem, but not the matrix.
Is it possible to have GERD and not being aware of it at all?
To have GERD? Yes, it is.
GERD.
Yes, GER, gastroesophageal reflux disease, GERD. Yes, it sure is. Now, some people don't recognize what heartburn is. Other people have reflux, but don't necessarily have the clinical symptom of heartburn. And then they come in later and they've got problems swallowing, and it's advanced. So I mean, it's just a function of our age. I mean, it's, I've got it. I've got gastric reflux. Yes.
Has there been a case they use a decellularized organ transplant for a solid organ? Or
Not yet. It's because right now, everybody working on the different organs is at the same roadblock, and that is when we decellularize it, we also remove all of the cells that line all of the blood vessels in the tissue, not just the big blood vessels, the capillaries, everything. And so when you hook the plumbing up, without a proper endothelialization of those blood vessels, relining them, the blood clots. Everybody's at that stage right now. Now just think about it. That's just an engineering problem. What recipe do we use to get the cells to endothelialize all the blood vessels? And then once we do that, then what route do we take to get the other cells in? Because we can't use the vessels, but now we have to put them in a different way. All solvable problems. But that's where everybody's stuck in every organ right now.
except the esophageal lining, that can be...
Well, that's a different approach. That's where we let the body basically recruit stem cells, change the macrophage phenotype, and instead of forming scar tissue, the body itself forms a new tissue. It's not perfect, but it's also not scar tissue.
One more question?
I'm sorry.
Is the insurance industry friendly to this?
They're no more friendly to us than they are to anybody. But there are lots of matrix products on the market for routine things, like ventral hernia repairs. So you don't need regeneration of tissues in those cases. You simply need something that's going to form something that's going to hold. So they're used there, and they're approved for applications like that. The things I've shown you, not yet, because what's going to have to happen is someone's going to have to say, okay, if you take this approach, we save more money. We don't spend as much money on you as if we don't. And I can tell you that this approach it's not just like expensive now, save money in the long run. This is less expensive to start with. Anyway, it's one approach to regenerative medicine. It's not going to solve all the problems, but it gives you a flavor of what's going on in the field. And so if we can, as your parts wear out, start to replace them with functional tissues, we'll be able to have a quality of life that will allow us to walk around, be friendly, not have, all of these post-surgical scars when we're 75, 85, 95, so forth. Thank you very much for your attention.
Thank you so much, Dr. Badylak.